Okay, so the topic of my talk today is multisystem inflammatory syndrome in children. And this is going to be a little update. There are no disclosures. So we all know that COVID-19 usually presents with mild symptoms or is asymptomatic in children and has excellent outcomes in majority of the kids that present with that. But MISC initially was recognized originally in reports from UK as a serious complication associated with COVID-19 infection. And these kids have had features of Kawasaki disease and toxic shock syndrome and required ICU admission. Later, the cases were identified to be temporally and geographically associated with outbreaks of COVID-19 infection. And majority of the patients were PCR negative, but antibody positive, which indicated past infection. In May of 2020, CDC issued a national health advisory to report cases meeting the criteria for MISC. I can't advance further. Okay, so in terms of epidemiology, this was a paper by Payne et al. Published in JAMA in summer of 2021. It consisted of 248 patients diagnosed with MISC from 7 different states, and multiple centers contributed to the data. The incidence was found to be 5.1 persons per million person months. The median age of those patients was about 8 years. The highest incidence was noted in those less than 5 years of age and between 6 and 10 years of age. Interestingly, the lowest incidence was found in those between 16 and 20 years of age, but it was thought that possibly these patients in that age group were getting care at adult facilities and were underrepresented in the data. There was a slight male predominance, but it was not statistically significant. And compared to Caucasian, the incidence was higher amongst Black and Hispanic population, about 9-fold higher. And then Asians had about 3-fold higher incidence compared to, I'm sorry, I don't know how it's like continues to do that. So in terms of diagnostic criteria, there are 6 diagnostic criteria. In order to be diagnosed with MISC, it has to be a serious illness that leads to hospitalization, fever of greater than 38 degrees Celsius that lasts greater than 24 hours. There should be lab evidence of inflammation, which there are multiple lab markers that are listed down the road in on one of the slides on a flow sheet diagram that I can go over. And then at least 2 organ systems should be involved. Patient should be less than 21 years of age, and there should be an evidence of current or recent SARS-CoV-2 infection in the patient themselves, which is usually confirmed by PCR or serology or an antigen test, or exposure to suspected or confirmed case of COVID-19 within the past 4 weeks prior to symptom onset in the patient. And then there shouldn't be any alternative diagnoses that can explain the presentation of the patient. This is a diagnostic pathway I have copied from American College of Rheumatology, and it was pretty neat. And I think our MISC inpatient pathway is pretty similar for diagnosis to this one. And that is also down the road in the slides, it's there. But I'm going to go over a little bit here. So initially, we have to see if the patient has all of the following. So they have to have an unremitting fever, epidemiological link to COVID-19, and at least 2 of the following clinical features listed here. If the answer is no to these, then you continue a diagnostic evaluation as per standard of care, and then continue to monitor for any development of symptoms that could be suggestive of COVID-19. If the answer is yes, then you go down this pathway, but still consider other etiologies because there is significant overlap between MISC and other fever and rash syndromes, as we all know. And if all other syndromes have been considered and there's less likelihood that that would be the etiology for the presentation, then you take the patient along the MISC pathway, and then in there, we have to see if the patient is hemodynamically unstable, in which case we'll have to do the tier 1 and tier 2 labs all together. But if the patient is hemodynamically stable, then you go the tiered pathway and send the tier 1 labs to look for signs of inflammation and some basic labs. And then if these are still positive, where the CRP is more than 3, ESR more than 40, and at least 1 lab feature suggestive below, then you do this perform this tier 2 labs and confirm the diagnoses, as well as start the treatment based on that. So Feldstein et al. In New England Journal of Medicine published presenting signs and symptoms of COVID-19 in his paper, and many other papers have talked about that as well, and I'll share our own data from Norton's as well. So persistent fever is the most common feature that has been noted in most of these patients. GI symptoms are predominantly seen, and about 90% of patients in his data had those symptoms. Cardiovascular sign and symptoms were arrhythmias, depressed function, coronary changes, pericarditis or effusions, and elevations of troponin or pro-BNP, which were seen in about 80% of patients. And about 75% of patients had mucocutaneous findings and hematological changes in terms of lab work. Hypotension, vasoplegic shock requiring inotropic support were seen in about 48% of patients. And the rest, neurologic symptoms and renal symptoms in the form of AKI were seen in a lesser number of population, but still pretty prominent. And younger children were more likely to present with Kawasaki disease-like features, while older children were more likely to present with myocarditis and shock. So this is the breakdown of his cardiovascular symptoms reported in his paper. There were about 80%, as we said, who had any kind of cardiovascular involvement, and the most prominent abnormal finding was noted was the elevated BNP, followed by any abnormality in the ejection fraction, and then elevated troponins. And then the most severe or significant findings that were related to cardiovascular system were ejection fraction less than 30%, so severely reduced, were seen in 5%. Coronary artery changes with a Z-score of more than 2.5 were noted in about 8%, and then ECMO support was needed in about 4% of his patient group. This is actually from our MISC inpatient guideline, which I included because it's a more comprehensive list of what could be the sign and symptoms under each category, and goes over in much detail. So I'm not going to read everything from there, but it's there for reference. He also reported disease severity and hospitalization, as well as the ICU admission rate. So 88% of his patients were hospitalized, and median length of stay was about 7 days. 80% of those patients required ICU admission, 48% required vasoactive medications, 20% required mechanical ventilation, 16% ECMO support, and 2% of patients died, and 40% had Kawasaki disease-like features as well. So when talking about the treatment, the goal of our therapies for MISC is to decrease inflammation overall and improve organ function. And most treatment, as we know, is extrapolated from other syndromes like Kawasaki disease and toxic shock syndrome because of the similarities between the entities. IVIG and steroids are frequently used in our center, as well as in most other papers that I read through in many centers across the US. Additional anti-inflammatory medications and biologics are added for those who are refractory to, who have a refractory disease with the use of IVIG and steroids. Low-dose aspirin is used, and it is recommended to be continued until normalization of platelet counts and establishing normal coronary arteries at least at 4 weeks from the initial onset of symptoms. And then other anticoagulants, such as Lovenox, may be necessary depending on individual scenarios. So currently it's recommended per ACC to add anticoagulation in the form of enoxaparin if the Z-score of a coronary artery aneurysm is more than 10, so a giant coronary artery aneurysm, or there is significant functional impairment, which is categorized as severe, so an ejection fraction of less than 35%. Would require additional anticoagulation and monitoring of anti-10A levels. Children with Kawasaki disease-like features should be reassessed 24 to 36 hours after IVIG infusion for any recurrence of fevers or ongoing inflammation signs. So we all know that there are many similarities between MISC and Kawasaki disease, but what are the differences that would tell the two apart? MISC is, as we said, is noted with a higher incidence in patients who have African, Afro-Caribbean, and Hispanic descent, and Kawasaki disease is more prevalent in those with Asian descent. MISC also encompasses a broader age range compared to Kawasaki disease, and patients have more prominent GI and neurologic symptoms, and they are more likely to present in shock. And when lab work is looked at, MISC patients tend to have a lower platelet count, lower absolute lymphocyte count, and higher CRP levels as compared to Kawasaki disease. And again, ventricular dysfunction is more frequently associated with MISC, but coronary artery aneurysms are more frequent to be noted in Kawasaki disease. But MISC patients who do not have features of Kawasaki disease can still develop coronary artery aneurysm. So it's not a absolute yes or no. Or it's not needed to require Kawasaki disease-like features for MISC to develop coronary artery changes. So what is our experience here at NCH? So total, we have seen 89 patients since the beginning of this clinic. And they met the criteria for MISC and were hospitalized for that. The age range was variable all the way from infancy to 20 years of age, and the average patient age was 9.7 years. 60% of those were male, 23% were overweight. And in terms of severity of presentation, 61% of those required ICU admission, 12% were intubated. Cardiac support was needed in 33% in the form of vasoactive medications or inotropes. And myocarditis was diagnosed in 42%, and this is based on elevation of significant elevation in troponins, depression of myocardial function, or the need for inotropic support. And then coronary artery changes were noted in 17% of patients. So this is the diagnostic algorithm we use here at Northern Children's Hospital. And as I mentioned earlier, this is pretty similar to what American College of Rheumatology has published in their most recent version. So I'm not going to go over the details because pretty much it's the same. This is our treatment algorithm. So all patients who were admitted with MISC, the first line and diagnosed with MISC, the first line treatment is IVIG. 2 grams per kilo, which can be given either broken down in the form of 1 gram per kilo on consecutive days, especially if there's depressed myocardial function. And then methylprednisolone, low-dose methylprednisolone is our choice of steroid. Antiplatelet and anticoagulation therapy is usually initiated, and as I said, aspirin is usually started in all patients, but the rest of the anticoagulation may be needed depending on the individual patient scenarios. If the disease is refractory after all of this first-line medications, then you may have to intensify the therapy, and usually rheumatology gets involved here. And anakinra is one of the biologics we have used more commonly, and also addition of some antivirals has been seen in some of the patients. So this is, again, the breakdown of what we have used. So IVIG, about 90% of patients had been treated with IVIG, and steroids were used in 82%, anakinra, which is the interleukin-1 antagonist, was used in 41%, and remdesivir antiviral was used in about 7% of patients. Now, what is the proposed discharge criteria after hospitalization from MISC? So about 3 to 4 days of downtrending inflammatory markers, troponin consistently declining and ideally less than 1 nanogram per ml and a normal EKG. 48 hours being off vasopressor support, 48 hours fever-free and without the need for supplemental oxygen. And then if they're discharged on Lovenox, then the anti-TNA level should be therapeutic. If there had been significant cardiac failure symptoms requiring medication, they should be controlled on oral medication with stable or improving findings on repeat echocardiogram. In terms of follow-up, this is from a combination of CDC and AAP and ACC all kind of combined on this slide after reading through. So general follow-up visit is recommended with the pediatrician in 24 to 72 hours after discharge. And of course, depends on the severity of symptoms. If they presented with more severe presentation, then your follow-up needs to be sooner than later. And due to unclear prognosis and potential risk of progression of cardiac manifestations, long-term structured cardiac follow-up is recommended by most entities. And initial follow-up at 2 to 3 weeks is recommended with an echocardiogram included at the time of the visit. For those who presented with Kawasaki disease-like features, a repeat echo at 6 weeks is also typical, and that's our practice at Norton as well. But in patients with myocarditis or coronary artery aneurysms, more frequent monitoring may be necessary depending on like the severity of the disease, the size of the aneurysms, and how the patient is doing clinically as well. Outcomes, generally, the rule is complete recovery in majority. Death is rare, and most papers report about 1 to 2% incidence. Majority of patients we had seen and at Northern Children's are back to baseline with normal echocardiogram and regression of all coronary artery changes and no functional impairment. One of our patients had persistent mild ventricular dysfunction noted on MRI at 3 months following diagnosis, but he is clinically doing well and remains asymptomatic. And there has been one death in a teenage girl at Northern Children's Hospital. Penner et al. In his paper from UK reports 6-month follow-up outcomes in patients, and 98% of his patients had a resolution of systemic inflammation. 96% had normal echocardiograms at 6 months, and all had normal cardiac testing. One patient had stable large coronary artery aneurysm, and there was one who had a small stable pericardial effusion. And 13% still had some residual GI symptoms. 39% had some residual neurologic symptoms in the form of weakness, dysmetria, some abnormal posturing, some abnormal eye movements, but none had more than minimal functional impairment. And 98% were back to full-time activities at the time of his follow-up. So in our clinical practice outpatient world, this is a pretty commonly asked question: when to participate. Sports clearance, I think, has been a main point of attention for the families, and pediatricians have been dealing with this a lot as well. So large registries from US professional and collegiate athletes recovered from COVID-19 have recently documented a very low prevalence of clinical myocarditis. Less than 1%. The subclinical myocarditis may be a little bit more, about 2%. So the return to play, the factors to consider before releasing a player to go back to the sports that they want to participate in would be the timing of COVID infection, the severity of infection, and then the type of physical activity or sports that is being considered. For those who have mild symptoms or were asymptomatic but had a positive test or exposure, the usual recommendation by AAP and ACC is not to restrict them, but they have to be 5 days from the original infection or original diagnosis, and fever-free with an asymptomatic for at least 24 hours prior to return to play. For those who have moderate disease, and if the cardiac workup is negative, the recommendation is gradual return to play after 10 days from the positive test and minimum of 1 day of symptom resolution off of any antipyretics. But if there is positive cardiac screening or there's abnormalities in the EKG, then cardiology evaluation is recommended for those patients. And then for those with severe COVID-19 presentation or those with MIS-C, the recommendation is to restrict them from exercise for a minimum of 3 to 6 months and cardiology clearance, including cardiac testing and possibly an cardiac MRI prior to return to play. And of course, all athletes and their parents, when return to play or cleared for sports, should be guided to monitor for any development of signs and symptoms that are concerning for myocarditis, in which case they should return to the provider and seek further testing if necessary. This is the algorithm from American College of Cardiology, and it's fairly recent, from January of 2022. So a patient with history of COVID-19 infection who has been asymptomatic for more than 14 days. If they have been asymptomatic or had mild symptoms, less than 3 days of symptoms, you just go ahead and clear them for participation as long as there's no red flags in history and the cardiac screening is negative. So no abnormal cardiac signs, symptoms such as chest pain, exertional dyspnea, palpitations, syncope, or shortness of breath out of proportion to the activity they are doing. For those with moderate symptoms, if they're less than 12 years of age, you pretty much treat them the same way as the asymptomatic or mildly symptomatic child. For those who are over 12 years of age and are seeking participation in high intensity sports or physical activity, a screening EKG is recommended. And if it is normal, you go ahead and clear them from participation. If it is abnormal, recommendation is to be evaluated by a pediatric cardiologist with testing. And if any of the testing is concerning for myocarditis, then you treat them along the severe pathway, which is if they're hospitalized, have abnormal cardiac testing or multisystem inflammatory syndrome, then you basically restrict them for 3 to 6 months and do longitudinal follow-up with testing, including EKG, echo, 24-hour Holter monitor, exercise stress test, and cardiac MRI may need to be considered depending on the individual scenario, and exercise restriction for a minimum of 3 to 6 months is recommended. Now, this is from Kentucky Medical Association Committee on Sports Medicine, and it's a little bit more conservative, and this is also fairly recent compared to the ACC and AAP. So if they consider from a patient with positive COVID-19 testing or presumptive diagnosis, if they are asymptomatic since lab diagnoses, they still recommend no exercise for 14 days after positive test and monitor for development of signs and symptoms during that isolation period. They recommend evaluation by a physician or MD at the time of clearance. And that clearance includes, of course, going over the cardiac symptom screen as well as review of systems, and consider testing if necessary. For those with mild symptoms or moderate illness, which is managed at home, they recommend a 14-day isolation from symptom onset of positive test and at least symptom-free for 7 days without use of fever-reducing medication prior to releasing. And at the time of releasing, again, similar criteria is used, so evaluation by a physician, and then symptom screening, review of systems, and consider testing if indicated based on the history. For those with severe symptoms who were hospitalized, had abnormal cardiac testing, or have MISC, or children who have prolonged symptoms lasting longer than 14 days, then you still refer them for medical evaluation by their primary care physician, but cardiology consultation is recommended for those, and cardiac MRI should be considered as well. This is the return to play after COVID staged guideline from KMA. So any return to play should be preceded by a gradual and progressive return to physical exertion. During that time period, during all of the stages that the athlete is going through, they should be monitoring themselves, and the family should be monitoring them for development of any signs and symptoms that are of concern and could be indicative of cardiac involvement of myocarditis. If there is any suspicion that there is concerning signs and symptoms, then the athlete should stop exertion at that time and go back to be seen and evaluated by the clearing physician or cardiology consultation. So this is broken down into 5 stages, essentially. Over a period of 7 days, and as you can see, it walks them through light activity and some time limitations on it and heart rate limitations on it, all the way to full activity in 5 different stages. And usually we give this out to the patients at the time of releasing them as well. And this is just a form, clearance form that KHSSA uses for clearance for reference. It's in there. So we have our multidisciplinary MISC clinic every Monday, and different specialties that are represented are cardiology, and usually I am the one conducting this clinic as well as rheumatology and infectious disease specialists. And our contact information for the nurse clinician to schedule any of the patients who need to be seen in that clinic is Christy Stewart with the number mentioned here. These are my references that I used to prepare these slides, and I'm open to questions.
Thanks so much, Dr. Maksud. That was really a great talk. We have one question in the Q&A currently, and let's start with that. Susan Hafner would like to know if you've seen any cases of MIS-C breakthrough or any cases of MIS-C in COVID breakthrough cases. I think that implies so vaccinated kids developed COVID and then got MIS-C.
I personally don't believe so, based on the data I've seen. I recently have not been doing the clinic for the past like 2 months, so I'm not sure if during that period we have any that came to attention. But as much as my knowledge goes, I don't think I have seen anyone who had completely been vaccinated. Now, there were a few patients, I think 2 of them, who presented with myocarditis-like symptoms after they had received their second dose of COVID-19 vaccine itself. But the one that I clinically followed actually just had acute presentation with chest pain and some like lingering, I think myalgias, had recovered within like the next 2 or 3 weeks and had a completely normal echocardiogram throughout that time. I think there was some elevation in troponin, which was pretty significant, but downtrending already by the time they were sent home, and required about a day and a half. Hospital length of stay was about a day and a half.
Yep, thank you. Nice paper in MMWR showing that vaccination is actually reduces the risk of MIS-C. So we can look at our data more. I'm not aware of any breakthrough cases either. We have another question. Have you seen any differences of MIS-C numbers after the different variants? So for example, Alpha versus Delta versus Omicron.
So regarding this question, I myself was curious because I have not been doing this clinic for 2 months. So I did touch base with our nurse clinician prior to the presentation while I was preparing. And I was told that since the Omicron is fairly recent and there was a lag from the time of Alpha variant when it came to attention to the development of MIS-C noted in children, we might be dealing with that window period where we're not seeing any. But as of my knowledge, I don't think there has been any surge in the cases of hospitalizations from the time Omicron has been has come to attention.
Yeah, I think for that one we stay tuned.
Yeah.
Because we're sort of entering that time period where we'll see it. I really appreciated your discussion of the return to sports. I think that's something that is a hot topic among pediatricians, particularly since that the CDC has updated isolation guidance and KMA continues to tweak that algorithm. So maybe we can actually send the current algorithm to everybody with those recommendations. So thank you again for.
Absolutely. Thank you very much.